So I'm going to go off script a little bit, given everything that's come before me, because frankly, I suspect we're doomed. And let me give you a little background as to why I think that. There's a couple of issues here, but my bias, I was 17 years the medical director of Nantucket Community and Family Services. We started that in about 1992. And the population in Nantucket was about 10,000, give or take, over the years that I was there. We had multiple deaths secondary to heroin or other narcotics each year until about 10 years ago when buprenorphine first became available. The reason that we had the deaths was that no one with opioid dependence was coming into the clinic. They didn't believe that we could really provide them much in the way of service. They weren't looking for medical care. Some of them went to counseling. But by and large, there wasn't very much available to them on the island. So we were losing folks every year. Well, 10 years ago, we started to provide buprenorphine through the clinic on the island, and we very quickly got to the 30-person limit that you're capped at under Data 2000. The cap then rose to 100. We very quickly rose to 100. Now, most of the patients were coming to us on the island, but the island only has 10,000 people, so obviously the 100 probably weren't all coming from the island. In fact, they weren't. A good percentage of them, about half, were coming from off the island. And that's fine. People are allowed to travel from one county to another to get treatment, unless you happen to be a resident of Nantucket and don't like the fact that narcotic addicts from off-island are coming to your island to get treatment. In which case, you'll go to the town and say, unless the clinic cuts off treatment to people from off-island for narcotic addiction, we won't support the giving of money to support the clinic anymore. Well, push came to shove, and about 3 years ago, the clinic basically said, we give up. We can no longer treat people with opioid dependence with buprenorphine, because they gave me a choice. They said, you have a choice. You can, as medical director of the clinic, either turn away everybody from off-island and continue to treat just the people on island, or you can shut it down. And I said, fine, shut it down. And I took all of the patients, moved to my office in Rhode Island, and I see them all there. And the ones who are on the island now come off the island, drive an hour and a half to see me, and then go back and take the ferry back over the island. That's absurd. It's ridiculous. I make more money this way. It's fine by me. The patients can't stand it. And of course, Nantucket no longer has the influx of people coming over the island to get treatment anymore. Interestingly, I've lost, as you might expect, some of the patients from Nantucket because it's a schlep and a half to get to see me. So what's happened since we shut down the buprenorphine clinic on the island? Heroin deaths went up. Just what you would imagine would happen, because other than a very small amount of buprenorphine being prescribed by some of the docs on the island, the clinic's not available anymore. So now, why do I start off there? Why do I start off with the we're doomed issue? Because this happens everywhere. It's not just Nantucket. To give you an example of what happened in my own town, after I moved back, I opened up my office in Lincoln, Rhode Island. Nice medical office across from the high school, in a medical building. There were other doctors around me. And I saw my general psychiatric and addiction medicine practice. Except now I was seeing 100 patients who were being treated with buprenorphine for their opiate dependence. Well, the other doctors didn't like this element coming to the office building. So they pressured the landlord. And the landlord said, you can't see that many of these people. Really? They're not doing anything wrong. They're not breaking any laws. The police have never been called in. They don't make too much noise. Yes, they get here a little bit early in the morning, but that's because they're driving 2 hours from the Cape and want to make sure they get here in a timely manner. No, not good enough. So we had to shut that office down. And my wife and I, we have 200 patients between us. We've been about 1,400 patients total in our addiction practice. Had to move to an old mill building in Woonsocket. Again, cheap for us, but the building doesn't look like a medical office. It looks like an old mill building. But we have no neighbors, so the patients were able to come and see me. All right, so here's my question. If faced with these kind of difficulties, how many physicians do you think would be willing to go to this extent to continue to serve this population? Not very many. And so we're sitting here right now, in the exact same position as the other doctors treating patients with buprenorphine for opioid dependence. I have a waiting list of 500 people between my wife and me. We're only allowed to see 100 people apiece and treat them with buprenorphine. We have 500 more people waiting to see us. We're private practice docs. We can stay open as long as the patients will keep coming into the office. I don't have any limitation, except with this disease. And that's another bizarre thing. With this disease, it's the only disease in the entire country of anything that any doctor treats where there's a limit set by a regulation that's federal that prevents us from treating the number of patients that exist with the illness. So if I want to treat all 500 people on my waiting list, nope, sorry, we can't. Why? Is there any reason other than a political one as to why? And moreover, why right now? You saw the statistics. The number of opioid-dependent people, for a variety of reasons, has been rising dramatically over the past 14 years. There's been no change in the cap for the past 10. So we're sitting here, limited in terms of the number of people we can treat. While the number of people with the illness grows and grows and grows and grows, there are no more doctors coming in to treat this specific illness. Right? We generate about 50 a year, but frankly, 70 a year are retiring from addiction medicine practice, so we're not even keeping up. We're not in a good place right now. Let me give you some other points, and I'll circle around back and hit the marijuana point, but I need to talk about opioids for a second because it all ties in. The first thing is, what's addictive disease? To have an understanding of what addiction is means that you have to understand that addictive disease doesn't have anything to do with drug use. Addictive disease is a disorder of the brain in which the brain perceives the world differently than it does in 90% of the population. It affects roughly 10%, 15 maybe. So I have to try to convince you, and you're going to be easy, it's the general public that's difficult, that 90% of the people aren't the problem. They're not the issue. Now let me boil it down. Let's say we all go outside, bright sunny day outside. How many of you would immediately put on sunglasses? Sure. Some of you did. The rest of you didn't. It was about 50-50. And that's what I get every time I ask that question. Why? It's the same sunlight, it's just as bright. The difference is that different brains are wired differently. We're set up to perceive stimuli differently, just as our heart beats at different speeds, our body temperatures, all are on a bell-shaped curve, heights, weights, IQs. That's the way humans are built. Some people are on one end of the spectrum, some people are on the other. So you go outside, it's a bright sunny day, you go, oh my God, it's bright, it's terrible, I'm going to grab my drug. And your drug happens to be sunglasses. There's no downside to sunglasses, no risk, no tolerance, no withdrawal. It works perfectly. It turns the volume down. Now, a good portion of people can go outside on a bright sunny day, they say, this is perfectly comfortable. I don't notice anything wrong. Addicts all start out with the perception that the world is an uncomfortable place. They're stimulus augmenters. They need sunglasses. When they discover the sunglasses, by putting them on, they feel better. Not different, but better, subjectively improved. So that when you talk to an addict and say, tell me about the very first time you used a drug, the addict's response is, I felt normal. I felt the way I think everybody else feels all the time. I felt right. You talk to a non-addict about how they felt, and they say, I felt different, I felt funny, I felt worse, right? Because if you take a stimulus augmenter and you give that person alcohol, for instance, they generally say, I felt nauseated, I was uncomfortable. I usually don't drink very much. But a stimulus augmenter feels better. That doesn't make the person an addict. It simply makes them susceptible. So what makes them an addict? An addict is part two of the problem. You take a person who's susceptible by being uncomfortable in the first place, and you make it so that they do not have an adequate coping mechanism. And you do that through bad parenting. You're either irresponsible, inconsistent, overbearing, punishing, hostile, absent. any of a number of issues can take place in childhood prior to age 7. By age 7, all bets are off. You're finished being programmed from that perspective. So if you lack the coping mechanism to deal with your discomfort, and you're then exposed to the drug, you're an addict. That's how you build it. It takes those 3 things. Now, the 3 things that I just gave you, one of them is pre-programmed, it's genetic, we can't fix it. The second one we could talk about through preventive measures in terms of parenting at a very young age. We could do something about that long term. But the third one is the key. You need to be in an environment like the United States that says drugs are great. And that's where we are right now. We're in the middle of a population that is sitting out there looking at adding a 3rd legal psychoactive drug to the system, despite the disasters caused by the first 2, because they think drugs are great. Right? Smoking is the leading cause of morbidity and mortality in our country. Alcohol is the 3rd leading cause of morbidity and mortality in our country. And yet I keep on hearing over and over again how prohibition failed. No, it didn't. From a public health standpoint, prohibition on alcohol was the best thing this country ever saw. Morbidity and mortality dropped like rocks. People did not die of alcohol-related disease during prohibition. There were law enforcement issues. There were criminalization issues, same as there are right now for marijuana. The public health was in great shape. Then they said, no, we have to legalize alcohol because we all love it. And so they did. And now we're sitting here where alcohol is the 3rd leading cause of death and sickness in the country. We wouldn't have ever had to deal with the ACA, remember the Affordable Care Act just a couple of years ago? We would not have had to deal with that if we had cut health care costs simply by saying, no more tobacco, no more alcohol. The entire issue would have been off the table because the health care costs would have dropped again. But no, we would never consider that because we want our drugs. Right? And that's what's going on first with opiates in an insidious method that sort of came from industry, follow the money on that one to figure out why. And second, with marijuana, which is coming in equally insidiously through industry, through the public. But it's still a follow the money issue. Because big marijuana is going to be as big tobacco. And they know. So let's look at opiates for a second, because what happened there is pretty straightforward. Doctors about 15 years ago had been told, don't use opiates, they're dangerous, they can cause problems, just as you heard before. There are the acute issues where opiates are good. Then doctors were told not just that opiates could be used long term, but they were incentivized, right? They were told specifically that pain represented a vital sign and that they had to work to get the patient's pain level down. They were also told simultaneously that patient satisfaction measures would now be taken, and that the degree to which they received bonuses, the degree to which they were kept on as an employee, was going to be based on their satisfaction rating. So, imagine, if you will, a patient comes into the ER, he's drug seeking, he's requesting additional opiates for his chronic pain. And the doctor sees him and says, I see you have chronic pain, what would you like for that? I'd like some Vicodin, doc. Well, what will my patient satisfaction rating be if I do not give the Vicodin? It would be low. I would therefore give the Vicodin. That will keep my patient satisfaction rating high and will keep me employed. Simultaneously, I might check the prescription monitoring program to take a look and see what has been prescribed to this gentleman in the past. If I'm bright enough to do that and I know, okay, great. And, oh, wait, the methadone that this guy is getting from the methadone center, that's not in the prescription monitoring program. So all of a sudden, for docs like me who focus in this area, it's only partial information. All right, I can get around that. I can try and work with the local methadone facilities and try and get some information, but I can't because 42 CFR Part 2 makes that impossible. So I can't get the other information that I'd like. And oh, wait a second, the patient could have just gone to Rhode Island or New Hampshire to get a drug, and the state prescription monitoring programs don't talk to them. So it's not perfect. And even from the side of the doc who wants to do right by these folks, we can't, because we only have part of the information we need. All right, so now we're in the middle of a situation that looks like this. That's a bar with the entire population. This is the group of people who are susceptible to addictive disease. And this is the group of people who were exposed to narcotics 15 years ago. Now what happens is a percentage of these individuals actually have addictive disease. Not everybody who's exposed to a narcotic has addictive disease. Only about 10 or 15% do. And you might say that percentage varies because the people likely to seek it out might have a slightly higher incidence. Not going to bother with that right now. As doctors were told, prescribe more of these drugs by various sources. They did so, but they did so without checking with each person to see, do they have addictive disease? Why not? Well, how do we do that? Let's say you come in and you've got addictive disease, but you've never been exposed to a narcotic. You have the first two building blocks. You don't have the third. How would the doctor possibly know that you have addictive disease and you're the one who's going to get hooked? Well, there are a few ways. They could start out by doing a drug screen and seeing if you're using some illicit psychoactive drug. They could ask you if you smoke. They could ask you whether you have a family history of addictive disease. They could even talk to you about your family and what it was like growing up. And each one of those things would give them a clue. But most pain docs haven't been taught to do that, and most docs prescribing narcotics haven't been taught to do that. And so when we talk to doctors and say, this is what you need to do, they say, well, we don't have time to do all that. We don't have the expertise to do all that. And there are so many people with chronic pain that we would just be flooded. There's no way of getting around it. And so it, in general, is not done. Now, SBIRT's one approach to that. There are a number of others that could be utilized, but there are more questions than answers in terms of exactly what these docs should be doing on folks who are narcotic naive, if that's the direction they choose to go in treating it, because a percentage of them are going to have the problem. Okay, so more people are treated with narcotics. Suddenly this number starts to rise. And so what we see is that curve that we saw before that basically says, all right, now we've got a lot of people using narcotics. They have narcotic dependence, opioid dependence. And now what do we do with them? Well, we can send them to an opioid dependence treatment facility, but they're full. Now, here's the next odd thing that's happening. So the buprenorphine facilities and clinics are full. We're at our 100-person cap. A person comes in to get the buprenorphine. We give them the lowest dose that they say they can tolerate. Now, we don't know for sure whether or not they're selling some of it on the street. There's no drug test in the world that I can use to see if they're taking the dose that I've asked them to take. There's nothing I can do to make sure they're taking that dose every day. Right? The pharmaceutical companies are working on additives, inert additives that will allow that to be measured. That's a few years off at the very least. So that can't be done. So these folks coming in to get their buprenorphine, they're selling some of their drug on the street to make a few extra dollars. Why does the drug have any street value, though, given that it has a ceiling effect and that people really don't get high unless they very much abuse the product, which most people aren't doing? Well, it has a street value because the doctors are full, because there's a 100-person cap. So the doctors are prescribing enough, frankly, to get some on the street so that the patients who can't see the doctor because the doctors are full have the access to the drug that helps them from their opioid dependence. Well, the regulators and lawmakers, not quite in Massachusetts yet, Tennessee, Ohio, West Virginia, see that and say, oh my God, there's this other drug on the street that shouldn't be on the street. We'll have to regulate it by cutting back on the prescribing of the buprenorphine. It's the exact wrong direction. Right? What you want to do is make it so the doctors can prescribe as much as they want. Then it would have no street value. Right? But that's not the direction folks are going in because the drug's expensive. So the managed Medicaid programs sit there and say, this is now the #1 drug in terms of cost. Used to be opioid dependence was cheap for us. Now it's the most expensive disease in the world because it has a drug associated with it that's expensive, and the number of people with the disease is going up. And so they look at it and say, we've got to cut the expense. Well, if you cut the expense and the prescribing drops, then the number of people who are able to get properly treated will drop. They'll end up going back on the street to get their drug, and the drug will continue to have a street value. At the same time, pill mills are being shut. And because the pill mills are being shut, all of a sudden you've got a bunch of people out there who were prescribed Vicodin, hydrocodone, you name it, who now don't have a way of getting treated for opioid dependence because the view clinics are full, don't have a pill mill from which to get prescribed narcotics. They get pushed to the street, and what do they get? Heroin. Because it's easily available and cheap. And so we expected, and in ASAM we said 3 years ago, shut the pill mills, don't change the cap, you will get a rise in heroin. We announced that in a press release 3 years ago. What did we see? A rise in heroin. No surprise, we all knew it was coming. Heroin's cheap, it's pure, it's available to be snorted. It was guaranteed that that was the only outcome possible, unless you opened up some of the other valves. No one opened up the other valves. So now we've got heroin being used, and more deaths. And again, entirely predictable. So, you know, as I sit here and say, we're doomed, it's because the things that make sense, that would open up the system and let it work the way it's supposed to work, aren't being done. And in part, they're not being done from a regulatory or lawmaking perspective. In part, they're not being done because the public simply isn't well educated enough on the topic. And so to switch over to marijuana, we've got the exact same thing. We've got a drug that has absolutely no benefit whatsoever. It doesn't do squat for a single medical illness out there. And yet, we've got a public out there saying, this is medical, it's medicinal, it will make you feel better. Well, sure, you go back 100 years ago, you could get those little bottles of, you know, Dr. Phil's magic potion, right? And what did it contain? Largely they were narcotic. And it would make people feel better from whatever they had, right? Well, marijuana does the same thing, so does alcohol, so will a swift kick with a hammer on your head. You know, they'll all take away pain to some extent. So most of what you're doing is making it so you can't remember what was going on at the time. Or it's making you stupid, or it's making you so you black out. And either way, you're going to go through and at the end of the day say, yeah, that felt better than yesterday. But it doesn't make you better. It's the same sort of thing as if I took somebody with tuberculosis and if I gave them methadone for their cough. They would feel much better. Methadone works beautifully for cough, probably the best drug out there for it. And yet, I've done nothing for their TB. Their morbidity and mortality is no better, not improved. So when you look at the medical data for marijuana, most of what we've seen over all of the studies that have been done, most of which have been small scale, not double blind, not placebo controlled, have at best a suggestion that there could be some improvement in one thing or another as a result of the marijuana use. Look at glaucoma, for instance. Intraocular pressure does indeed drop during the use of marijuana. If you actually wanted it to work for glaucoma, you would need to be stoned all day long, every day. That's the only way it would work for glaucoma. If you wanted to work for wasting disease in, say, end-stage HIV or some other cachectic illness, okay, yes, it gives you the munchies, you can gain a little bit of weight, no question. But there are other things that work better. And indeed, if it's end-stage, a terminal disease somebody has, I don't care what they do. They can smoke as much pot as they want. If they feel better, good, go with God. But in terms of 99% of the population, you know, in Rhode Island, the average person receiving a medical card for marijuana use is a 30-year-old male with a history of substance use disorder. That doesn't make any sense. These people don't have chronic pain or wasting diseases. And now Rhode Island wants to add PTSD to the list. I can't think of a worse thing to add to an allowance for medical marijuana because we've got plenty of literature that shows that the big problem in many of the folks with PTSD is the concurrent substance use disorder. So we're sitting here with a public that's had the wool pulled over their eyes, that has the suspicion that there is not only no risk, but medical benefit to the use of a drug which, one, is much stronger than the drug that was available in Vietnam. Two, causes psychosis in a significantly higher percent of people than you would otherwise expect to get it if they weren't using marijuana. And a drug that's been demonstrated to cause neurologic structural abnormalities that are probably responsible for the loss of IQ that takes place. And the loss of IQ appears, not certain yet, to be permanent. When is it permanent? It's permanent in the kids who use it. Kids being anyone under 25, because the brain doesn't stop developing until 25. So we're sitting here looking at a drug that has known negative outcomes that are significant, right? If I just, let's see, if I had one little factoid here that I think is interesting. Here we go. 7 studies have shown a 40% increased risk in psychosis in marijuana users compared to non-users. And if marijuana use starts before age 18, there's a 6-fold increase in schizophrenia later in life. Now, you could try and make an association. You could try and guess, well, the people who are going to get schizophrenia might have some abnormalities even before they get it. Maybe that's driving their marijuana use. And so maybe you're self-selected somehow. All right, I could buy that to a little extent. 6-fold? Do we think to a 6-fold extent the schizophrenics are self-selecting even prior to having any signs of the disease? I don't think so. I think marijuana is causing it. And the research seems to be more and more supportive of that outcome. So if we've got a 6-fold, let's even call it a 4-fold increase in psychosis. If you were 17 and you were told, you can try this drug, but it will make it 4 times more likely that you'll be psychotic, would you really want to do that? You probably wouldn't. Maybe you'd think it through a little bit. But if you're told, this is a medicine for a lot of people, and it has no bad qualities to it, and it's legal, by the way, you can buy it down the street. Would you use it? Well, of course you would. Right? Now, even better are the states that say, oh, we don't allow anybody under 21 to buy the drug. I think we have that rule on tobacco and alcohol. How many people have friends or patients that you've worked with who started using alcohol and tobacco only after it was legal? Does anybody know anybody like that? No, because that's not the way it works. That's what high school bathrooms are for. So you sit there and say to yourself, why would we expect this to be different? It won't be different. It'll be the same thing. So, really what this boils down to is this question of in what direction do we want society to go in over the next few decades? Do we want society to be in a position where, we've just accomplished so much with tobacco over the past 30 years, right? I was in medical school in the late 80s, and patients were smoking in their hospital beds. They would take their oxygen mask off, and they would smoke. The president of the board of the hospital, Mount Sinai, would smoke during board meetings. There were ashtrays in the back of the seats in the medical school, right? I mean, this was routine in the 80s. You could smoke on airplanes and trains, in office buildings, anywhere you wanted, grocery stores, you name it. It was all there. And now, that would be absurd. If somebody walked into a Stop and Shop and lit a cigarette, and that's not going to happen. But just a few years ago, that was normal. So we've made huge gains. Why do we want to take a step back? Why would we possibly want to impose that unless the public really believes that this particular carcinogen, this particular drug that causes stupidity, really, is something that should be used? Right, that was the one point I didn't make here, that 8 or so point drop in IQ. I had an argument, I went to MIT for undergrad, and I had an argument with some of my marijuana-using friends there who say that they've never noticed a problem with their marijuana use. And I said, well, you started out with an IQ that was, up a little bit, and you came down 8 points. So let's say you started at 130 and now you're at 120. Yeah, I don't think you're going to notice a whole lot. But if you look at the socioeconomic spread of people who tend to use drugs, they start out at a below average point for the most part. So if you're starting out, let's just say it's 90, right? 90 IQ, all right, you can do most things. You can get out there and get a job and be productive. But now you're lowered to 82 on average, right? How competitive is an 82 likely to be in the U.S. in terms of getting a job? How productive will they be? And that's what the state legislatures have to focus on. Because all they do is focus on money. All right, good, let's focus on the money. You'll bring in tax revenue by legalizing and regulating marijuana. But you'll end up with a less productive population with higher morbidity. Not within the 2-year election cycle, unfortunately, but longer term, right? These people are going to end up costing you money. And we can look at tobacco and alcohol for that. 10-to-1 ratios, right? For every dollar brought in to government by taxation, the government spends 10 from different silos, admittedly, on health consequences and productivity losses and disability, right? Why are we adding another drug? Didn't we want to keep costs low? This would not be a good idea. So, I have plenty more I could say, but I know I'm out of time, and I know that there's a question and answer section, so I want to leave that open. So, thank you all for listening to me.